Oh, good morning, afternoon, everyone. This short presentation is to explain a fundamental issue that we have in the UK, and we also know that exists in South Korea. This is identified through extensive research, where surgical services delivery is very much unpredictable. We in the UK, we have extensive waiting lists and lots of cancelled patients. And in a time of COVID-19, when we're trying to optimise the use of all of our resources as efficiently as possible, this can't continue. So we have to do something fundamentally different to address that problem. So my name is Dr. Matthew Bacon, and I'm the founder of TCC Casemix, and we've developed a suite of technologies really to get to the bottom of the problem of poor surgical predictability. In the UK, we find that 54% of all procedures typically overrun, and 43% of them finishing early. Typically, when surgery is planned, most surgical planning teams use best guesstimates and averages, and we have averages for the duration of the operating procedure that's being planned. And we've seen from the research that's exactly the way it's often done in South Korea as well. So we share the same problem. Before COVID hit us in March, we were already seeing escalations in waiting lists. And at that time, 4.5 million patients in the UK were awaiting surgery. Other research was done to show that critical care patients, 300,000 of them a year recurring, were being denied surgery because of all of the underruns. Every time there's an overrun of surgery, typically there's a cancelled appointment. When there's the procedure finishes early, we end up with theatres standing idle, so not making use of the available capacity. So COVID-19 has caused this national backlog, and that has extended that 4.5 million into nearly 7 million on the latest statistics. And in that, we've got something like 30% of all patients, that's from World Health Organization statistics, are suffering pain and suffering because they are musculoskeletal disorders. What we've been doing in Casemix is to bring this back down, the challenges back down to an individual level. Every one of those 1.5 million patients, 4.5 million, 7 million, wherever the perspective is, has a personal set of issues that to be addressed. But they have a profile. And what we've been doing is analysing the patient risk factors that drive surgery. Typically, when surgery is carried out, none of this kind of information is used in the planning. We're taking these profiles and correlating the risk factors that each one of these people presents, along with issues like surgeon years of experience, to much better forecast the predictability of the surgical planning that has to take place. So what we've been doing is to identify a fundamental challenge for both of our health sectors, is that we have very poor knowledge about surgical duration within surgery. It's recognised by a number of leading industry reports in the UK, and there's a major national initiative addressing this issue at the moment. But commonly they say we don't have the data. And Casemix is unique in this process because that's what we've been doing. Collecting the data, feeding the evidence back into a preoperative assessment planning process where we can then start to look at what the patient needs are from a planning perspective alongside all of their biometric analysis, and feed the new set of data about forecasting surgery into a scheduling system. So what we've been doing is collecting this data that doesn't exist at the moment in a real-time tracking system in the operating theatre. We're working in Hungary at the moment, and this is some work that's been done in the UK. Some theatres are connected in real time to the internet, and they can use our system as a cloud service. And here, this is a standalone system in a packaged up into a briefcase that the surgeons can use alongside the operating table to actually record the actual time of all the detailed procedures that gets carried out. Typically at the moment, you only record the patient coming in and the patient leaving. Here we're recording all of that detail that's necessary. So this is an advocacy by one of our major groups. We need to acquire this data comprehensively in real time. That's what we're doing. And so what we're able to do is to take this patient cohort and we collect all the data around patient demographics, surgeon risk profiles, and everything is automatically coded at procedure level in our database. And we can correlate, you can't see the detail of this, but this is all the sub-procedure detail in surgery correlated to the activities that were carried out during surgery for specific patients. In this case, we're analysing suturing and how that's carried out by different methods and different semi-robotic devices. That enables us to create different patient profiles demarked by their demographics and their risk factors. So for the same patient going into colorectal surgery, for example, or same patient group, we can break the group down into different risk factors and then provide a statistical analysis of which group is going to take how long through each part of the process. So the point is we're achieving predictability of the planning, and in achieving the predictability and therefore much better list completion, we're able to increase productivity. So then we bring all this data down into dashboards so that the management team, the theatre management team, can now start to see the correlations between different risk factors and the impact on surgical duration time. So now we get the predictability that we're looking for because we've allocated the patient risk factors to different cohorts, and then we plan accordingly. And all the data that's captured in real time, passing through a data quality processing system, so we can identify where there is any breakdown in the quality and track that accordingly through the system. So what we're doing at the moment globally is we're looking for acute hospital partners to work with us to help us to acquire the data so we can improve the predictability of surgical procedures, and by doing so arrest this growth in backlog of patients and turn it around so that we can, through the significantly improved productivity, reduce our national waiting lists. Thank you.